Okay, so this all is this.
Yeah.
40 years of research and teaching. Gee, I can give 40 years of research and teaching. 15 minutes.
I can hear it. I can hear it.
I don't know if anyone else can hear it. Is it all right if I walk?
You can. I'll follow you. But if you get too far over there,
No, I'll just do right here.
perfect, perfect.
So why
Test,
introduce
test,
you?
test.
You're lost. So it will be 15 minutes. Never seen before.
Oh, I didn't. I did protest.
I was trying to.
Well, come.
Almost time.
But he didn't show up until like y'all just missed each other.
I would have put it in.
Oh, yeah, I was serious.
Right, yeah.
Are you ready? Ladies and gentlemen, please. The grand show is about to begin. It is my pleasure to introduce our dean, Robert Gregg Evans, who is going to talk to us today about his 40 years of research in teaching in public health and in medicine.
Thank you.
You're welcome.
Well, as you can imagine, 40 years is a little bit difficult to summarize in an hour. And over those 40 years, I've done what, looking back at it, 3 pages of something or another. So I'll probably go through it relatively quick. And I think, okay, what's the advantage in if you even come in here listening to something like this? I mean, I'm not certain. Some of you come and go, it's the dean, I feel obligated, I need to be here. Some come here because, you know, they're interested in their career and moving forward, and so they want some idea of what, you know, one person's career has been. And so, in going through this, it is probably will be beneficial to some people just to get an idea of how one person, starting at the age of, oh my gosh, starting about the age of 21 or 22, I started doing really basically some type of academic work. And I've done that until I'm retiring at the end of June at the age of 72. So there's a number of years there. You know, I started out with the idea of what was I going to do with my life when I graduated from undergraduates. I don't know if any of you have ever had that feeling. Probably not. You all probably knew exactly what you're going to do. I didn't. So what happened to me was that I graduated with a degree in psychology, a BA in psychology. I didn't do very well in school. I had really no preparation. I basically almost didn't even get into college because my grades in high school were so poor. And my English teacher, I know, going to my minister at that time, I'm Jewish now, but then I was Christian, so I go back and forth. Went to my English teacher and said, I'm really worried. I went to my minister and said, I'm really worried about Craig. He's spreading these rumors around town that he got into college, and I know there's no college in the country that would accept him. So that's the way I sort of started out. Came from a relatively poor family, and with no real interest. The family had no interest in academia or education, so it was always a tricky thing. So I was living in New York City at that time, in Greenwich Village. You all know what Greenwich Village was? Maybe not back in the 1970s, but Greenwich Village in the 1970s was the heart of hippiedom, the bohemian type of town. So I was living there, and I graduated with the BA from a university out in Long Island, Hofstra University, and I had some debts. I know none of you probably have any student debts, but I had some student debts. And so I decided, hey, I got to get a job. I got to do something. And what do you get a job with a bachelor's degree in psychology? It's not really the easiest thing to do. So at that time, I happened to be married to a Navy nurse who was also doing some part-time work at one of the hospitals in Greenwich Village. She said, just go there and just apply for any job you can get. So I went there and looked at it and that stuff, and they gave me a job as a secretary to the chair of the Department of Cardiopulmonary Medicine at that time. And he was in the process of typing a book on critical care medicine. He actually, Dr. Steve Eyre, he actually coined the title critical care medicine. It had never been used before that time. So we're talking about a long time ago. And he ran the critical care, intensive care within that hospital. And over the years, ended up publishing tremendous amount in critical care. Well, I didn't know anything. I didn't even know much about even what a doctor did. So I was there, and I was typing his manuscript. Well, his manuscript was on a word processor that was a little bit larger than this table, literally. And you typed on these little cards, and you had to move the cards around to move from one page to another page and so forth. And when it typed, you had to wear these heavy earphones because it was so noisy to be able to do that. So I started out doing that. And I did that for probably almost a half a year or more. And he called me into the office one day, and he said, I've been doing this study on looking at the bridge and tunnel workers in New York City and looking at their impact of air pollution on their pulmonary and cardiac function. And he said, I have collected all of this darn data. I'm not certain what to do with it. Can you do something with it? I said, of course I can. That's the first lesson right there for the students in this room. I had one course in statistics, in psychology. I got a D in it. And I said, of course I can. So, had this piles of data. I went home, I opened my little black stat book. And statistics at that time wasn't all that sophisticated. It really wasn't. And, and I was able to do some, t-tests between some of the groups and a few other types of things. I don't remember exactly what it was, but I brought it back to him and he was happy with it. So I finished typing the book, and he said to me then that, he needed someone really to run this project, to really go out and start collecting pulmonary function tests on all of the people at the bridges and tunnels. And he said, can you do that? I said, of course I can. So what did I do? First thing I did, I went out and I bought a camper, one of these big, huge campers. I think I paid $22,000 for it. I didn't pay for it, but the hospital paid for it. And then I had it equipped with all this pulmonary function testing equipment. And I started driving it from tunnels to bridges and getting the men through it and testing all the men in terms of their pulmonary function. So I did this for quite a while, collected a lot of data, brought the data back, did some statistical analysis on it. Most of this was done using a calculator, by the way. We didn't have computers yet. There weren't computers. This was on a calculator doing this type of work. So I did this and for over a number of years, and we published a number of papers based on this. And he was very generous. I mean, he usually made me, second author on most of the papers because I collected the data and done the analysis, even though I didn't understand half of what I did. It didn't matter. And then we also wrote a major paper on the whole history of air pollution and how it was dealt with. And so I did this. And this was very interesting. I got my name on that paper. And then I get a call to go and testify before Congress on the impacts of air pollution, particularly at that time. There was no catalytic converter. They were thinking and working on the direction of start to require catalytic converters. So I go and I sit before this, committee, a little old 22, 23, 24-year-old, I don't know how much, but I was young, very young, and trying to testify on some of the work that we had been doing in air pollution. So that was sort of the start of my career, which I guess is quasi-public health, but I really didn't know that much about public health at all. I mean, I just didn't. All I had was a bachelor's degree in psychology. And the Dr. Ayers, the person I spoke about that I did the book for and did much of this research for, he became my mentor. And it became probably some of the really important turning point in my life because he was such a good mentor. And he was one of these people, which I try to tell medical students and this stuff, his undergraduate degree, it wasn't in biology, it wasn't in any of the physical science. What do you think it was in? English. He was an outstanding writer. He could pull all of this stuff together and he could write so well. I mean, he almost sit down in one draft of a paper. So he became my mentor. I worked with him in terms of research, and we really had a very good relationship up until the point I didn't get my PhD until 1986. This is back in 1970. I didn't get a PhD until 16 years later. He was by then he was the dean of the Medical College of Virginia. He actually flew back to sit on the committee for my dissertation. After all of these years. And what I remember is I had a really difficult chair in my dissertation. I think I'd rewritten my dissertation 28 times by then. And I guess I was told about this afterwards. They were in the meeting, they were discussing my presentation, and this chair said, yeah, I think it was really good, but maybe he should do X, Y, and Z. And it was told that Steve Ayers slammed his fist down on the table and said, enough is enough. And so the only thing that really got me through so quickly. After doing much of this research in New York City, Steve Ayers took a job as chief of medicine in Worcester, Massachusetts, and I went with him. And so what do you think he needed done there to start out with? He needed a laboratory. A cardiovascular laboratory in which you do all of these types of chemical analysis for a lot of the studies he was doing. And he asked me to set the lab up. I'd never had a lab course in my life. But I knew who to call, what to do. We got this set up. I hired a director, a chemist to work on there, Dr. Rao. And we got the lab set up. And then we started doing clinical studies. Clinical trials. And I got involved in doing the clinical trials. So he had a fellow that had come over from Germany and had done her residency and now her fellowship here by the name of Hilton Mueller. Well, Hilton Mueller became now the second most important person in my research career. This lady was dynamite. She was so smart, so powerful, so just a dynamic person. I remember, I shouldn't even tell this one, I'll tell it anyway. I really haven't watched the clock because I'm not even through the first page. But anyway, she was the type of lady that she had this armoire, antique armor. Her office was all fixed up with all of these antique furniture. Well, she had this antique armoire in one corner, and she always kept it locked. And the joke was, that is where she kept all of the residents' private parts. She was that type of individual, but she really was a #1 researcher. And so she and I started working on these clinical trials. We're collecting all of this data in the intensive care unit. And basically, I became the project director of these projects that we were doing in the intensive care unit. So I was getting calls in the middle of the night from the residents saying, hey, we got this patient, we just admitted them, they have X, Y, and Z. Do you think we should admit them to the study? I've never been trained in medicine and that stuff, but I learned what I needed to learn. And I said yes or no, that we should put this into the study. And then I would get up. And at that time, I just moved. I came there and I would go to the hospital and I would work with them all the night in collecting data on these patients in the intensive care unit. And at that, related to that, we published papers. We published one paper based upon work we did looking at the impact of propranolol on reducing the amount of damage to the heart. We got it published in the #1 cardiovascular journal there was. Last time I looked, it had over 2,000 citations. And this was the type of work we were doing with her. And how did we do the work? We still didn't really have computers. We would take the data, we'd sit down at her desk until 2, 3 in the morning, doing things on a calculator. I would do the statistics. She wasn't much of statistics. We would hand draw out the figures for the journal articles, which would then go in, and the journal would then change it, make them more professional. We would hand draw out what we would submit to the journals at that time. And I mean, we just worked on this stuff. It was a wonderful time. It was a wonderful time because I was learning so much, working with her daily on this. And so we did this, and it was, it was really a very important time. I'm losing track of where I am. Did I do this before or after that? Yes, this was before that. Then it came up that we needed looking at some animal models to look at what was popular then was what types of interventions and drugs could you give to be able to reduce the amount of damage after a heart attack. The whole concept was that is there drugs that you could get that would increase collateral flow to the heart after a vessel was occluded. So I had read someplace about animal model on a rat. And I said, hey, I can do this. So I got a bunch of rats and I started operating on the rats, popping their hearts out, tying off their coronary artery, popping the hearts back in, sewing them up, and they lived. So I developed this model for doing this. And I mean, you have to realize I killed probably 100 rats before I got this model worked out. But then I was operating on 60 rats a day and working on those things, collecting data on using all different types of intervention, differing drugs to look at it, and then leave the rats go for 2 or 3 weeks, kill them, take the hearts out. And before that, I would usually inject some types of radioactive isotopes into it, cut the rats out. We would measure then how much damage was done to the heart by using these radioisotopes, and being able to do that and seeing did one drug or another drug help reduce the amount of damage that was being done to the rat model. And then we invited a fellow from Warsaw, Poland, and she had a PhD and an MD, and she came over and started working with me in the lab. Well, by then we had changed from working on rats, we were working on dogs. Some of these say I could never do it anymore. I love animals so much. But back then we were working on dog and dog models to be able to look at the same thing, the impact of various types of interventions. And we were putting all types of instrumentation on these dogs and then sewing them up and letting them go about their business for the next few weeks. So she and I did a lot of this work. We did this over almost a 2-year period, off and on. And she went then back to Poland. And she said, why don't you come back to Poland with me? And we'll continue the work back there. So I said, why not? So I left my job with Steve Ayers, and I took off and I went to Poland. And I would spend 3 to 4 days a week working in her lab, but every other evening, I would spend the time with her husband working he was chief of surgery for the major hospital in Warsaw, and I would spend every other night in the OR, the operating room, with him doing operations on trauma cases that would come in over the evening. They didn't have a lot of rules there. I mean, I was sewing patients up and handing instruments, and about the only Polish I knew. And I did this for 2 years. And it was a wonderful time. It was during communism, so it was a little rough living in Poland because there wasn't a lot in the stores and so forth. But it still was really a learning period for me. I still only had a bachelor's degree. You have to realize, even at this point. So I came back after 2 years. I wrote Steve Ayers, and I said, I'm coming back. What job do you have for me? And he said, well, we're just starting with Hilton Mueller. By now, she's no longer a fellow. She was becoming chief of cardiology in the hospital that they were at that time, which was in St. Louis, Missouri. So they said, well, Hilton needs a administrator of cardiology. So this was now we're getting the health services type stuff, or health administration, hospital administration. And I said, sure, I can do that. So I came back and took over as administrator of this brand new cardiovascular unit. And so we were spending, every other night out at these fancy restaurants recruiting physicians. So it was a time of exposing me to something different than I had ever been exposed to. I mean, we were the best restaurants that were in St. Louis. We would take these potential applicants for physician roles in this newly started cardiac care unit. And when I came back, I continued also, while I was doing this administrative position, I still continued all of my animal research. And so by then I was still doing rats and doing some dogs and so forth. And in 1977, I expanded my work to working with baboons. So now I started doing all the cardiovascular work on baboons, and even starting to do some work on, very early on heart transplants. And so working on baboon as the model in this little lab that I had at the top of a steeple there in the medical school in St. Louis, and doing a lot of these types of studies, in which we also then received a number of grants, and wrote a lot of papers to be able to write up the results that we had from the studies I was doing with baboons. And then in 1978, I became the co-principal investigator on a multi-institution NIH grant to compare animal models. And the idea was that could the results that we were getting from the interventions in animals to reduce the amount of damage after a heart attack, could it be duplicated in more than one model? So Harvard had a model to look at long-term dogs that they would basically cause a heart attack in, give an intervention, and then carry that out for 2 weeks, and then sacrifice the animal, and again see how much damage was done to the heart. And they did that. And Johns Hopkins did an acute dog model, which they did the intervention, but they sacrificed the animal right away. And I had the rat model, because I was really the only person in the country that had this type of rat model. So I had the rat model for this, and we would then, each of us would have to use the same intervention, and we would compare the interventions between the different models and see if we could get the same results that we were getting some really good results in my rat model. Could we duplicate those results in animal models? So we did this, and we did pretty well, except one of the Harvard study, which was done by a Harvard fellow, was not the bottom of the bottom. But anyway, it was not in agreement with what we were getting in my rat model or we were getting in the acute dog model. And so NIH brought statisticians in and started looking at it, and basically found out that the fellow was fabricating his data. He was taking data for 2 days, extrapolating it out for a number of days. And of course, his career was ended. It also did a lot of damage to a very famous cardiologist, Eugene Brunoise, who ran the lab and was always on the papers, but really never had time really to look at the data or anything like that. And that's now, if you see in many of the journals, medical journals, you see that when you send in an application, you have to indicate the role that everybody on the article, all the authors, what their role was. And they have to indicate that they had direct involvement in either the writing of the manuscript, analyzing the data, or doing the type of stuff. Well, that came about because of the study. I mean, because of the faults of the study that I was working on back then. So, okay, and then at that time, then I had the opportunity with a grant from the American Heart Association to start looking at blood pressure of Afro-American men living in depressed areas of St. Louis. So I was going out with a team of individuals, and we were taking blood pressures and looking at various factors that would contribute to why they had much higher blood pressures than non-Afro-American populations. And so I did that basically for almost a year. And then I had the opportunity to be the co-principal investigator on a multi-million-dollar grant to evaluate the effects of dioxin exposure. Well, dioxin, if you don't know what dioxin is basically, you've heard of Agent Orange during the Vietnam War? Anyone? Okay. Agent Orange is basically a pesticide that was produced in southern Missouri at a plant. Well, what happened was that dioxin is only a byproduct of it. You don't want the dioxin, but dioxin forms in the development of this Agent Orange. Well, in the bottom of the barrels in which they were doing the processing would be the remnants, and that had very high dioxin levels. And they hired a firm to carry it off to a hazardous waste site. Well, this man who carried it off wasn't all that smart. He said, why should I waste this really good looking oil taking it to a hazardous waste site? So he had a second business, and that business was spreading oil on dirt roads throughout Missouri. So instead, he spread it to a community called Times Beach. And you probably read about that in your environmental health books if you haven't. And he spread that in Times Beach, and a number of years later, someone came across it really by accident. There were some horses that died in a stable, in a horse arena that was in that area. And when they were doing the investigation of it, they found out there was very high levels of dioxin in this community. So we went in, we did a study of all the people in the community, we collected blood, everything you could think of, psychological tests. I mean, we did multi-million-dollar study in there, which resulted in moving everybody out of Times Beach, relocating them, digging up all the soil in Times Beach, incinerating the soil, which would do away with the dioxin. And that all came about because of the study that I was involved in, which I was co-investigator, but I was actually the project director for the whole study. So then in 1986, I got my PhD and became the principal investigator on a follow-up project to look at these individuals we moved out from Times Beach and to go back and to reevaluate them, particularly on some immune function testing that we had found were abnormal. And so I had a study to go back and reevaluate these individuals on those factors. So I did that, and then that was followed by, became principal investigator on a study to look at chloridane levels, which is a pesticide that gets washed off of the agricultural fields into the river. Okay, well, the concern was with subsistence individuals that ate more than 5 pounds of catfish and carp from these rivers. And the idea, what would be their levels of chloridane in their blood after eating such a large amount of fish? And this study I just loved. I love this study. I was going out these dirt roads to these subsistence homes, dirt floors, heated by wood fire, and it was just these people were so wonderful, just so wonderful. But they basically lived off of fish and killing squirrel and this type of stuff. And so we would go out and take blood from them out in the middle of nowhere, sometimes by light of the car lights, to be able to do it in the evening and taking blood from some of these people. So we did this, and I traveled all over the state because we were looking at the Missouri, Mississippi rivers in terms of their impact. And so I did this, collected this type of data. We looked at it. We found out that there's relatively high levels of chloridane in certain parts. And so then we were responsible for working with the state and Missouri Health Department to basically close those parts of the river off. And they were warnings put up on all those parts of the rivers not to eat the fish that was coming from those parts of the river. And these were all field studies. My stuff I did with dioxin, with chloridane were primarily a lot of it field studies, which is a lot what epidemiology was. By then, I was calling myself an epidemiologist. I took a fair number of epi courses, but my PhD was in health services research. So doing these types of environmental epi studies were really a lot of fun. But then really over the next 25 years, most all of my work was in lead poisoning in children. So I had, over that period of time, what did I write down? Yeah, I received over 7 grants, major grants, to look at lead poisoning in children in various situations, including where I spent time in a small town in the mountains of Peru that had a huge lead smelter. And the children living in that area, when we would do blood tests on those things, their lead levels were just skyrocketed. So, and it was basically because the smelter was very few controls, and it was at 16,000 feet. So we would land in Lima, which was at 0. We'd get in taxi cabs and drive up 16,000 feet in one day. We had people in our group that went up to help do the study that couldn't get out of bed for 3 days. after they got up there, because going to that height was really very, very difficult. But we had, you know, it was a good study. It was being sponsored by the Catholic Church, the diocese of that area, looking because they had seen this impact on these children. We were seeing behavioral impact, decreases in IQ, all different types of stuff with these children that were living in that area. So I did that along with doing studies on housing conditions in St. Louis, Missouri. But probably the longest study was, the most grants, was looking at the remnants of lead mining. Missouri was at one time, was the largest lead producing state in the Union. And they had these huge piles of remnants from the lead mining. And people were living in these areas. The dust from the piles were blowing into their house. They were breathing all this stuff. So we did just numerous studies, not only looking at what was the impact of the lead mining waste in terms of their blood lead levels, but then we set up a large number of intervention studies in which we would go in. You know, one of them, we hired professional cleaners to go in every 6 months to clean the house because of a lot of the dust in the house. We also did studies in which we dug up the soil from that was contaminated in certain areas. Other studies where we had grass planted on these huge piles of waste. Just a lot of studies trying to find the best way of reducing the exposure of the children. And it was very difficult. Nothing really worked well. Nothing worked well. Because it also, not only were they getting exposure from what was coming off the mine waste, but they were living in old homes that had lead-based paint. So you had both to deal with the lead-based paint plus the exposure from the waste. And then in 1997, I received an EPA environmental justice grant to develop an environmental hazards concert for metropolitan St. Louis, in which we dealt not just with lead, but with a number of environmental hazards that were taking place in the whole region. We brought experts in from the whole region to do this, and I basically organized that. But then in 2000, strange things happened, was that I was approached by a senator, Senator Bond, who is, well, you probably don't because none of you are political scientists, but he was a fairly well-known senator at that time in Missouri. And he approached and said, you know, I'm really concerned about the potential of a bioterrorist attack. And I really need something developed to be able to study this. So he gave the university I was working at $1 million to start a center for the study of bioterrorism. Okay, and I was the director of that center. So I basically put together the center. We started producing educational material, doing lots of research in terms of basically just book type of research. What is really known out there about the various bioterrorist agents, and putting together sheets that were worksheets that were explaining them, one page explaining what could be done, how you test for it, and so forth and so on. And then this was 2000. Then 9/11 came along, and it just blew up the work that we had. I mean, I was on television and radio at least a dozen times a day because there was nobody out there doing anything in bioterrorism. And we had all of these training material and training sheets, which really served as what CDC used then for the next whole year till they developed their own. These sheets talking about bioterrorist agents. Now, why bioterrorism? Well, after 9/11, there was this big fear came about that that the next thing would be to use biological agents against us. So that's why that basically came about. So that was a very interesting years of trying very diligently to put all of this material together, and it turned about that we got then grants from EPA, CDC, and HRSA, and all of these areas. So we over that period of time got $5-6 million in grants, basically to work on the areas of bioterrorism. By then we expanded it somewhat to biosecurity in general. So we were looking at chemical agents also and nuclear agents. So this whole stuff. So we had this center, and there weren't a lot of people out there really trained in this area. So I decided to start, as part of the School of Public Health, an MPH and a PhD in the area of biosecurity. So I put together that program, developed the courses, hired the faculty and so forth to teach in it, and we put together this whole program of MPH and PhD that's running to this day. And we trained large numbers of people in this area that then many of them took jobs at CDC and state health departments and so forth, because there just was really very little known about this out there. So these are some interesting areas because it gave me the opportunity to actually develop, programs in these areas. So in 2005, I traveled to China to spend time there looking at how their response to SARS, because it's really much tied in with biosecurity and that type of stuff. How did they respond to SARS in such a way that was able to make a relatively significant difference in reducing the spread of SARS in that country? Okay, so I went over there, interviewed people at the health clinics and the China CDC and so forth, and looking at how they responded. And it was amazing. Like they built a hospital with a total isolation, negative flow hospital out of brick in 2 weeks. And it had 150 rooms. So, I mean, it was they used over 10,000 workers to build this. So their response and how they went door to door and how they quarantined people who had SARS, but they would quarantine them in home. They would go there on a daily basis, bring them food, make sure, take their fever and so on. So they had a tremendous program that we learned a lot back. I brought back, then shared with CDC, and much of what was being set up as far as the stockpiles and the various types of protocols that were put in place to be able to deal with either a naturally occurring, which is what SARS was, or a terrorist event using biological agents, and how it was done. And then they had a couple of years later, then there was the influenza outbreak. And again, China had learned a lot from the SARS, but they were responding to influenza that was taking place in that country. It was coming from Vietnam and those surrounding countries. So I went back to China and spent another couple of weeks there talking to people and working with them in terms of how they were responding to this. I didn't speak Chinese, but my brother-in-law, who is a political scientist, went with me, and he and I published a number of papers based upon the studies that we did there around SARS and influenza in terms of the response of the government to these types of things. It's interesting. I was looking back that, in the 40 years I've been in academia, I've published 67 papers. It really isn't a lot, in terms of what I've seen other individuals do. But I was involved in so many things other than just research, with starting these programs and this new Center for Biosecurity and so forth. So it wasn't too bad. But I'd also presented papers at over 100 venues and done over 300 television and radio interviews during that time, including one with Diane Green's show, which was really interesting because it's very controversial, because my belief in money that needed to be put toward bio preparedness and bioterrorism against another person, I can't think of his name right now, was well known back in public health, who believed the money was being wasted putting it there and should have been put in just general public health center. I sort of changed my mind over the years, but that was my belief back then on her show. And this was done while I developed and taught, 13 different courses in the MPH and PhD programs. I know faculty, some of them talk about developing, 1 or 2 courses or all this stuff. I actually developed 13 courses, and they were in every area you could think of. We didn't have a lot of experts back then. And we didn't have the same accrediting agency that said what you could do. So I was teaching courses, during that period, in epidemiology, environmental health, social behavioral aspects of health, health services research, bioterrorism, public health preparedness, and others. Of course, I developed because we had we had this new MPH program, and we were developing concentration. We needed people to develop courses and to teach in it. So I did that, and then went through a career, became, I was actually made the division director of environmental health the year after I got my PhD. And the reason was I already had several dozen publications in the area of environmental health, and they needed someone to start that division. So basically was that, and then over the career time became associate dean, became department chair, and we only had one department, and it was matrix. One department, so I was over all of the various concentrations, and did all of this until I eventually came here as dean. The biggest thing that I learned was it's really difficult, and for me it was pretty much impossible, to do research and do administration. So you sort of have to keep that in mind. If you're really doing, upper level administration, it becomes very difficult to do research. And so that's the thing I learned. Do I miss it? Yeah, I think so. But I think after, 33 years of academia, of doing research and teaching and that stuff, it's been a really a good change to come in and do dean work. So that basically, I summarized 40 years, giving you plenty of time to ask questions, and you better ask questions or we won't be able to go to them. Question? Yes?
So the grants that you received, did you also write the applications?
Oh, yes, all of them. I wrote them. Some of them I had no help whatsoever. Others I did have, co-investigators that helped. But no, I basically wrote all of the applications for all the grants. Yeah.
Why would you choose a PhD over an MD? Because you were doing a lot of surgery. So.
2 things. One, I couldn't have gotten to medical school for anything under the sun. With my grades, forget about it. Number 2 is that I learned over the years of working with physicians. It's not what I wanted to do. It just was not what I wanted to do, particularly a practicing physician. Long hours, doing the same thing over and over and that type. So I really wanted to be a researcher. I didn't know that when I was young. When I was your age, I thought about it. I'd love to go to medical school, but I knew I couldn't get in, so I didn't worry about it. And but in retrospect, I'm really, really happy I did. Yeah.
I was wondering, you've worked on a lot of projects. Which one was your favorite and why did you have a favorite?
Probably the whole area of bioterrorism, biopreparedness. I was able to start from the beginning. There was nothing being done in that area. And being able to do it from developing educational programs, communication programs, developing courses in that area, developing a center in that area, and really gaining, national recognition in that area and being able to do it from the beginning. It's sort of why here, even coming here, this was a relatively new school of public health when I came here. And so it was also fun being able to to sort of start some new programs, to get involved in some stuff that hadn't been done. So anytime you get that opportunity to get on anything, at the start, it can really be exciting to be able to see the changes that take place during that period of time. Yeah.
Was that the dough run plant in
Yes.
Peru?
Yes.
Now, isn't that associated with a plant in St. Louis?
Yes.
as well?
Yes, it's the same one. The one that did all the waste that I told you about, that we did all that was had been mined by. It went through a number of names, but the last name was the Doe Run. Before that was the St. Joe Mining Company, but Doe Run bought all of those out. They had the one in Peru. They were very difficult to work with. They were unwilling to do anything that they weren't absolutely forced to do, and the government was hesitant to do things. And even the community. There was no other jobs in that community except working for that mining company. And so closing the mining company down, sure, you might have reduced the lead levels in their children, but they had no work. How do they feed their children? This was the quandary we had. This was a horrendous quandary of how do we deal with this situation from a political standpoint? What do we advocate? And so we pretty much advocated various programs, get the children out, get their schooling by at least take them out 6 or 7 hours away from the city where schools were established so that they were away from the lead for periods of time. Various types of controls that were put in place in the lead smelting operation itself, but it eventually closed down. There was just got expensive, and the government putting pressure on everything, and which is good in some ways, but bad in other ways, because it was the sole source of revenue for that town. Even the shops, everything in town still were dependent upon the workers that would come. And those are one of the big quandaries that you have in public health, is trying to balance being able to do good in terms of the health, but sometimes you impact negatively the health in other ways. And so it's a real quandary. And I know it's a real difficult thing we had to deal with. Yes. Come on. There has to be some. Yes.
What would you say is one of the best and worst moments of your career?
Actually, there's probably a number, and the worst one probably was the health department, state Missouri Health Department asked me to go out and talk to a company that had their. It was basically just a trucking company. It was close to a place that had done some work that produced some dioxin. And they really weren't exposed, but they wanted me to go out and talk to them and explain to them that they're really not exposed and where they're at and stuff. It got so heated because they didn't want to believe me. I'm a government stool, all that stuff. One guy came up to me, got right in my face and was hollering and screaming at me, and then turned around and had a heart attack. So, I mean, that was a, you really felt bad. You were doing what you believe. Really, there was nothing going on part of the dioxin, but they didn't want to believe you. And then when someone has a heart attack because they get so upset about it, that was one of the worst times. One of the best times, boy, there's been so many of them. I really can't say. I really can't. There has been just dozens and dozens of wonderful times during that career of things and doing. Times being out in the community, being out doing. I mean, the best part that I look back of much of my career was the field work that I did in public health. I look back on the animal work, and I know it made a contribution at that time for areas that was not known. I became such an animal lover after that. I can't even step on an insect in my house. It really traumatized myself because when you work with not only rats, but when you get all the way up to working with baboons, and even for a period of time, I was working with cows, assisting with heart transplants. So, yes.
Thank you for sharing your academic life with us. I didn't know you were in so many different research areas.
Yeah, I don't think most people did.
I vividly remember the morning of 9/11, and actually had a former student of mine in one of the towers that came down, and it was a morning I don't think I'd ever forget. How did you take that?
I was at, you won't believe this, I was at a CDC meeting. There was about 12 of us sitting around a table in Athens, Georgia, and it was a meeting on terrorism. And I was sitting there around this table. The cleaning lady came into the room and said, I think you all should look at what's happening on the television. Well, the chairman of this thing just kept going. And I finally I said, I really think we need to take a break and see what's going on. So we walked out just as we were seeing on television the second tower fall. So that's where I was, a meeting on terrorism with CDC.
I was given a quiz that morning. Student came in and said, Dr. Stevens, the Twin Towers attacked. I said, no, I did not know that. And I went down to the dean's office, and he had his TV on, and we saw the second tower. So I went back to the class, and I said, do all of you know what's going on here? And many of them did not. I said, so I told them. I said, do you want to take the quiz? They all said no.
I mentioned that. It's quite a trauma. Other questions? Come on, we got 6 more minutes. Come on, come up with some questions. I mean, you've got a bunch of students in here. Yes.
There's a YouTuber that has a question.
Okay.
They say, Dean Evans, what's your perspective on the future of public health? I am particularly interested in job market and research grants.
Well, I think the future of public health is bright. I think it's gotten brighter and brighter as I've gone through. When I was very early on in public health, where most people didn't even know what public health was, or if they did, they thought it was a public hospital. Because that's back at those things, there were a lot of public hospitals that provide free care and that type of thing. That's what public health was. But now, still we haven't gotten totally people understand what public health is, but we have. We've gone from 39, well, it's even less than that, but the time I remember, when early on in my career, we had 39 schools of public health in the country. We have 64 schools of public health in the country now. We did not have an undergraduate program in public health. We didn't have many of the concentration in public health. All of this has grown, and it's grown, and the people that have graduated from those programs have gotten jobs and gotten good jobs. So yeah, I think that the future of health is good. Things go up and down with funding. There's no question. Things go up and down with whoever's in the presidency. If they have a strong interest in public health, funding in areas go up. If they don't, funding in areas go down. But if you look at it over the whole history, it is an upward slope. Yes.
I have more questions. Moving forward, will you act as a consultant?
Probably not. Probably if people need consultants in building furniture, probably I will. But I'm not going to do a lot in academics. Certainly I won't turn something down. If someone needs something that I know something about, but I'll be so out of it in terms of keeping up on literature in any area. I'm going to be in my workshop, 24 by 36 feet. And I'm going to be building desks and chairs and dining room tables and that for the rest of, as long as I still have the strength. I'm looking forward to it. Yes?
I had a second question. How did the Chinese build a hospital in 2 weeks? They work 24 hours a day?
Oh, and 10,000 workers. 10,000 workers.
All military, I think, right?
No, they had a lot of military, but it wasn't only military. Because they needed a lot of people with expertise. They needed, stonemasons and, just everything. But it was, I visited the hospital. Every single room was a negative pressure room. every room in that hospital. The strange thing is that it never got used.
What do you want to see for our college as we move forward?
Well, I think it's important to look at what trends are out there and trying to be in a position to be able to respond to it. You know, the latest thing we're putting together is, you know, some people might ask, well, you know, is this PhD in health policy? And the reason is I just really feel that we need more people with public health training in the policy arena. And so this is why I thought it was an important area to get started. I think that we have to be able to respond more to the training opportunities of people that are working in public health that have little or no training in public health. And I worked in Missouri with so many health departments where you had one nurse and some clerical people. The nurse had no public health training. And be able to provide the opportunity, not only putting new people in there, young people that are graduating into these positions, but also helping to retrain a lot of the people in there. So this is really why the importance, in my opinion, the importance of distance education. I think distance education that's targeted to the right groups of people, of retraining these people will be very important. And I think then the other thing is not to go into areas just to be growing. I think that is difficult as a school. You know, it's really important to pick those areas where there's a real need and where we can make a contribution as public health people. You know, so often you get to the areas where, you know, you look at programs because they can bring additional students, additional money in, and that's not the reason for starting a new program, in my opinion. I started that Center for Bioterrorism because there was a real need for it. There was nothing being going on. It's what made it so exciting. And I think at the School of Public Health, we should be doing the same thing. We should be looking for those areas where there's a need and where no one else is doing it or no one else is doing it well, and do what we can to fill those needs. And some of that need might be just for the region we're living in. I don't mean that it has to be a national need, but there might be needs for things here within our own region that need to be filled. And we should be the ones that should be stepping forward to help fill those areas related to public health. Yes.
Dina first. I mean, I agree with you that there is a need for more education for both practicing professionals and for young professionals who want to take up jobs. But I think a lot of the challenge, and especially in rural America, also in rural Georgia, is that there's not enough money in those local governments who could pay the salary for someone with an MPH. So even though people receive more education, even a BRPH, but once they have all this student loan, when they have the higher degree, they don't want to return to the same job for a lower pay, and so it still doesn't meet that demand.
I disagree to some degree. People, even in these rural communities, they are paying much higher salaries than what they were paying for these types of positions. We're not being able to send people out there that are going to make tons of money. Will they make a comfortable living in the communities they're in, particularly rural communities? I do believe that they will definitely make a comfortable living. And I think that's what it is. You don't go into public health to make money. You just don't. You go into public health because you have a dedication to public health. And for that reason, you will find the jobs out there that are satisfying in public health, in which you feel you're doing something, you're making a difference in the communities you're working in, and that's what counts. And as long as you're making enough money to live a reasonable lifestyle, then that's probably about all you're going to hope for. I mean, and then some people will decide to go into different directions where they go into research and work for CDC, or they work for state health departments. State health departments pay very well in public health. So there's a lot of various types of opportunities. And now we're seeing even more with opportunities in the industries, particularly with health promotion and prevention. I mean, so many of these companies, you know, it depends on what the economy is, but many of these companies are saying, hey, we can really benefit by having someone that can help keep the health of our workers in a preventive way, and we'll save money. That's what corporations look at. And so these would be more and more community health people and health promotion, health education people. And that can be even at the undergraduate level. Yes. I'm out of time. That's why Bob is standing. Thank you all.